Only studies containing homogeneous open and closed treatment groups should be included in the meta-analysis. Good morning, sir. Good morning, sir.
Yes, madam.
Today's topic is predictors associated with need for open reduction of pediatric supracondylar humerus fractures. Most studies were, yes sir, 2024. 2024. Most studies were retrospective comparative studies with level 3 evidence. The methodological items for non-randomized studies instruments were used for quality assessment of the included studies. This tool consists of 12 questions aimed at appraising multiple factors. Items are scored as 0, which are not reported, 1 reported but inadequate, and 2 reported and adequate. Maximum score for non-comparative studies is 16 and for comparative studies is 24. Preoperative predictive factors. Preoperative predictive factors of interest included all reported demographic, injury, and administrative factors that were compared between closed reduction percutaneous spinning and open reduction internal fixation. Demographic factors included age, gender, ethnicity, race, and body mass index. Injury characteristics comprise the following: affected arm-sidedness, dominance, Gartland classification, open versus closed injury status, fracture patterns, and neurovascular status.
Okay. So this is very important statement. Injury characteristics comprise the following: affected arm sidedness and dominance, Gartland classification, open versus closed injury status, fracture pattern, and neurovascular status. That is a very, very important. Yes, finally,
administrative factors included the following: time to treat, treatment location, treating surgeon's pediatric fellowship status, and years of experience. Sir? Important. Forty-nine clinical studies were included in the meta-analysis submitted. There were 94,415 patients, 11,329 treated with open reduction internal fixation, and 83,086 treated with closed reduction percutaneous spinning. Factors that were significantly associated with the greater rates of open reduction and internal fixation included obesity, Gartland type 4 fractures, general neurological deficits, and ulnar nerve deficits.
So majority were treated by closed methods. So only 11,000 out of 94,415, 11,329 treated by open reduction internal fixation, and 83,086 treated with closed reduction and percutaneous spinning. So majority with closed. So then what is the criteria? You said obesity, Gartland type 4, nerve injury. So how it differs?
It's based on the demographics, sir.
What demographic?
So whether the wound is open or closed.
That is for surgery methods. Surgery methods also there,
deficits.
And the status of the fracture also there.
Neurological deficits, and whether we are able to fix it by closed reduction or not.
So excessive closed reduction maneuver should not be done. That is also important. That if you do more of closed reduction maneuvers, there is high chances of myositis, joint stiffness, elbow joint stiffness.
Other nerves, radial nerve or median nerve. Other nerve. What does it matter? They didn't mention. They only mentioned general neurological deficit. Other nerves. Maybe. Gartland type 2 and medially displaced fractures were significantly associated with lower rates of open reduction and internal fixation. Secondary analysis showed cross-pinning constructs and longer hospital stays are more likely to be observed in patients undergoing open reduction internal fixation compared with the closed reduction and percutaneous pinning. Discussion. The purpose of this study was to determine preoperative predictive factors associated with the utilization of open reduction internal fixation techniques as opposed to closed reduction percutaneous pinning in pediatric supracondylar humerus fractures. A systematic review and meta-analysis of all the studies was conducted, published and available on PubMed from Jan 1st, 2010 to March 15, 2023 to determine whether the identified preoperative factors contributed to the operative modality as well as commonly reported outcomes.
Preoperative predictive factors, what are they? It depends on the fracture site or depends on the height?
Type of the fractures.
Can you say the moment you see the X-ray, can you make out this will go for open reduction or this will go for a closed reduction? Can have
Based on the X-ray also, we dislocation, posteromedial or when it is type 3 fractures, we go for mostly.
the X-ray, can you guess some of this is definitely going to open reduction or this we can manipulate?
If it is comminuted, we can go for open.
So if the spike is there,
The spike is
nearing the skin, dimple is there, open line, then that is open
puckering is
reduction.
open reduction.
Other than mentioned everything, we can discuss about this thing.
Yes, sir.
Preoperative prediction, how to make this will definitely go for reduction. I can say this is cross displacement definitely goes. Spike under the skin definitely goes for that. Other things we can try
We
to
can
manage it.
close to
That's
it.
what right discussion.
Gartland type 2 and medially displaced fractures. Obesity was positively predictive for open reduction internal fixation, likely because of higher mechanism of injury based on the increased patient mass as compared to those non-obese. Childhood obesity also affects the bone mineral metabolism, which increases not only the risk of fracture but also displacement. Multiple studies have identified pediatric obesity to generate more complex and adult-like fracture patterns. They found obesity to be a risk factor for open reduction internal fixation because of the increased difficulty with closed manipulation beneath a large traumatized and soft tissue envelope. The obese patient presents many challenges to the orthopedic surgeon that may influence the decision to expand direct fracture visualization and ensure the construct stability.
Obesity is a problem of manipulation one. Obesity along with this swelling one more factor.
First, in childhood obesity, it affects the bone mineral metabolism, affecting the calcium absorption, and it will leads to more fracture pattern.
The factor or just
It will lead to fracture.
manipulation regular healing.
Also, soft tissue envelope, more soft tissue envelope leading to difficulty in closed reductions. Fracture characteristics were significantly related to ultimate surgical method used to treat supracondylar humerus fractures. Higher Gartland class, especially type 4, where the posterior osseous hinge and periosteal stability were absent, was more likely to require open reduction internal fixation to stabilize the fracture while securing with the internal fixation. Supracondylar humerus fractures patterns such as Gartland type 2 and 3 were not associated with an increased need to open and were likely more easily closed reduced before the internal fixation.
So type 4 is one of the indication for open reduction and dislocation. So type 4 is fracture dislocations. Usually when you say type 4, the majority of the type 4 supracondylar fractures as for Gartland are age group also varies, demographic age. So fractures and displacement more common between the age groups of 5 and 8, whereas the fracture dislocations are more common beyond the age of 8 or 10 years, ideally 10 years, and the left side is more commonly affected, dominance and the age group and body mass index and associated factors like neurological deficits and all those. All are taken care into importance. Yes, sir.
Preoperative general neurological deficits and specifically ulnar nerve palsies were associated with using open operative techniques. Nerve palsies typically represent a larger, more diffuse soft tissue injury surrounding the fracture that occurs in a predictable pattern. Large soft tissue injuries facilitate more edema, swelling, and potentially a more difficult environment for the closed fracture manipulation and maintenance of the reduction, requiring other more invasive techniques. A study by Sun et al. Investigating only flexion type of fractures identified ulnar nerve palsies as a predictive factor for open reduction and internal fixation.
What about other nerves? What are the nerves involved in supracondylar fracture?
Median nerve and radial nerves can also be
Which is
Common is in this one.
ulnar nerves.
Ulnar nerve. I have seen it. How many have seen it?
in practice. This is in practice.
Median nerve.
In the 2 years, no? Did you come across ulnar nerve or a median nerve or radial nerve? Which one?
Median nerve.
Median, you have seen. How did you make out? Patient has come with a fracture. Then this is a median nerve injury there. How do you make out?
We check for opposition. Opposition, sir.
Yes, index pointing in.
Index pointing index. Whether it is making to
Ulnar nerve,
abduction and adduction of the fingers.
but which is commonly we see 1, 2, 3, which is ulnar nerve common or median nerve most common or radial? Different books say different things. One say ulnar nerve is common, then say median nerve is the last. But all three are supposed to be involved. Depends on which.
Based on this displacement, fracture displacement.
So this is anterior intraosseous nerve. Anterior intraosseous nerve is a branch of
Median nerve.
median nerve. Very good. That is more commonly seen in practice.
Although flexion type supracondylar humerus fractures were not found to be predictive of open reduction internal fixation in our study, ulnar nerve palsies, which are typically accompanied by flexion type fractures, were associated with open reduction internal fixation. When assessing the intraoperative techniques, there was heterogeneity in describing and labeling certain configurations. Reported surgical approaches were almost equally divided between posteromedial and posterolateral approaches to the distal humerus. This likely represents large rotational deformity in the fracture pattern, necessitating opening manually and obtaining a reduction before the internal fixation.
Surgical approach is it commonly posterior or anterior?
Surgical approach.
Posterior.
Posterior. But book says anterior. It's easy to do anterior approach or posterior. You know what approach is for the elbow. For supracondylar fracture, which is anterior or posterior won't go.
Posterior.
Why? Why not anterior? Commonest described procedure for SC fracture. Posterior or anterior? Both are described, but commonly done is posterior. Anterior also can be done only if it is a flexion type injury. That's indication. But this is what we had a discussion about this anterior posterior. Difference. What difference is there? Which approach will produce myositis more than other approaches?
Anterior produces more myositis.
No, posterior does more. What is posterior approach? Chance of getting myositis more than the anterior. But I have not come across. It must run very too long.
When there is a puckering of skin, when there is a vascular deficits, so that time you have to go by the anterior approach, but you have to have the in toto analysis of the case.
More than half of the open techniques that reported on pin configurations used cross pins. Cross pin configuration, although inherently imposes a high risk of iatrogenic nerve injury, has been shown to be biomechanically superior to the alternative pin configuration. Within these evaluated studies, the surgeons were likely faced with very unstable fracture pattern types, in those cases requiring open techniques, and therefore took on more risk with cross pins to achieve the greater fracture stability. There is increasing trend to treat the pediatric supracondylar humerus fractures in an ambulatory setting. It has been shown to be not only cost effective but also safe, with very low rates of postoperative infections and complications. Our study demonstrated longer hospital stay for those patients undergoing open reduction internal fixation, likely because of continued postoperative prophylactic antibiotics and evaluation of the neurovascular recovery. There were many limitations to this meta-analysis, to include the limitation of eligible studies during our data collection period. a high heterogeneity on both preoperative demographic information as well as reported outcomes, and scarcity of the adverse events, making direct comparison difficult. Most studies included in this meta-analysis were level 3 evidence retrospective comparative studies. Ideally, a prospective studies would be preferred for meta-analysis. However, prospective studies are limited in the literature.
So 13 years, retrospective, level 3.
Conclusion. This meta-analysis demonstrates that the factors such as obesity, fracture displacement, and concomitant nerve deficits are more likely to require open reduction internal fixation as compared to the closed reduction and percutaneous spinning.
It is not only the ear,
They did not, in this journal, they involved the nerve injury.
Yes, and the majority are closed.
Probably they have excluded them.
Obesity is more common there or here? This is done somewhere Western country compared to India now.
India, we rarely see obesity.
Vacation, but 1 or 2% they may get obesity, but other thing normally are not. The problem here is delayed presentation. What to do is what I would say. Delayed presentation of the proper action survey. So they go for proper action or close it action. Delayed presentation.
Open.
After 2 weeks here,
Opens.
no one comes immediately.
Open.
Very few.
2 weeks is too long already. Some scales would have
Children's. So that's what children's supracondylar fracture 5 and 8 years is more common. So those times fractures, undisplaced or fracture displacements are common. More than 10 years, fracture dislocations are more common. That is a difference. Go back to the conclusion. Conclusion. Slide పెట్టమ్మా. ఏంది ఇది ఓవర్లాప్ అవుతుంది. 3 పాయింట్లు అదే దాంట్లో